CBC, we find that hemoglobin is very low. During this time, when we evaluate the patient further, patient may have laboratory evidence of multiple myeloma, and then we evaluate and diagnose the patient to have multiple myeloma. There are specific tests which help us in diagnosing a patient to have multiple myeloma, and we usually do it in a stepwise manner. The first test we usually do is a CBC, and CBC will show low hemoglobin, low platelets, abnormal WBC. After that, we do an LFT, which will show an reversed AG ratio where the globulin quantity is much higher than the albumin quantity in the individual, and this reversal suggests to us that this patient could be having multiple myeloma. After that, we do a comprehensive multiple myeloma protein panel. This test includes serum electrophoresis, serum immunofixation, serum immunoglobulin levels, serum light chain ratio assay. Basically, it is nothing but a test where we see whether the two light chains, that is the kappa and the lambda, the proportion of that is within the normal range or not. We do a skeletal survey, and we also do PET CT scan in certain circumstances. Along with that, we do certain stratification related tests such as beta 2 microglobulin and LDH levels. When all these test reports arrive and they are highly suggestive of myeloma, we do a bone marrow aspiration and biopsy testing. In that test, we not only look for the pathological features of multiple myeloma, but we also send them for certain tests, molecular tests, as well as genetic tests such as the FISH testing, and then tests to detect which kind of myeloma risk that this patient has, whether it's a low risk, intermediate risk, or a high risk. So a battery of investigations are done to actually not only diagnose but also to risk stratify the myeloma so that we can give the appropriate treatment for the patient. There could be certain additional tests that can be done. We call it as a comprehensive metabolic panel to look at calcium levels, the uric acid levels, the serum creatinine of the individual. Then we also routinely do testing of the urine for 24-hour urine collection for Benz-Jones proteins, which is not so commonly done now. Nowadays, we usually do urine immunofixation testing, urine electrophoresis testing is also being done. We check for the proteinuria. So a lot of these tests are complementary when we finally have a patient who's diagnosed with myeloma, but they are very important in the management. Sometimes patient may have features of high concentration of these paraproteins or the N proteins, for which we may have to do serum viscosity testing. It is not commonly done all the time, but we may resort to doing that when patient needs these tests to be done. Most of the complications of multiple myeloma are basically relatable to the cytopenias that we see with multiple myeloma. If the WBC counts are abnormal, or if there is excessive production of the abnormal immunoglobulins and reduced production of the normal immunoglobulins, we may have recurrent repeated infections in the patient. It could be in the form of pneumonias, it could be in the form of urine infections, it could be in the form of just developing repeated cold and cough. So repeated infections are very common. Bony problems. Patient may develop pathological fractures because of the weakness of the bone after the myeloma cells have eaten the majority of the thickness of the bone. They can also have just bony pains because of multiple lytic lesions. They can have headaches which can be attributable to the lytic lesions in the skull bone. They can also have kidney problems. Kidney problems could be in the form of abnormal urine output. It could be in the form of renal stones, and these can all cause renal failure. Sometimes patient presents to us with kidney dysfunction and we do a dialysis, and during this time when we are trying to evaluate the patient, we get to know that this patient primarily had myeloma and the kidney failure was the result of the myeloma. Patient can present with cardiac dysfunction, heart problems because of very low hemoglobin which was not diagnosed or not treated properly. Patient may be having a lot of tiredness. Because of the cardiac failure, patient may even require to be given multiple units of blood transfusion to make the hemoglobin normal, after which the cardiac dysfunction or the heart dysfunction may or may not improve. So So these are some of the very important reasons that patients present to us at the hospital. Just like many cancers, even multiple myeloma needs to undergo staging evaluation so that we can stage the multiple myeloma into stage 1, stage 2 and stage 3. So this staging is done by the multiple investigations that we do and some of the risk stratification genetic testing that we do for patients who are diagnosed with multiple myeloma. In general, stage 1 means that the multiple myeloma is least aggressive. Stage 3 means it is the most aggressive, and the stage 2 means it's an intermediate stage where patients, depending on how they respond to the treatment, may live for multiple years or not. In my experience and as per the books, patients who have the low risk multiple myeloma with the treatment can survive for more than 10 years also. Those with stage 2 can survive for 5 to 7 years, and those with stage 3 sometimes find it difficult to survive beyond 1 or 2 years. So staging is very important so that we can give the right intensity of treatment at the right time and make sure that the patient can actually fight the multiple myeloma in the best possible manner and live as long as possible. Multiple myeloma patients can present to us either in an emergency or either in a non-emergency state. So whenever a patient with multiple myeloma presents to us, the immediate treatment that we provide is to basically give symptomatic relief. Patient may be having bone pain, so symptomatic relief by analgesics can help in the bone pains being relieved. But we have to be careful of giving analgesics for a patient with multiple myeloma because there could also be a kidney damage which may worsen if you give certain medicines such as NSAIDs. So we take care that we give the pain medicines which will not damage the kidney, and we also take care that the kidney damage, if at all it is there, is not increased by giving hydration, by improving the metabolic parameters and so on and so forth. There may be patients who present with extreme weakness, and the weakness is due to probably anemia, and this anemia can be easily managed by giving blood transfusions. If there is bleeding, then we give platelet transfusions to make sure that the platelets are in the normal range. If the patient has symptoms due to hypercalcemia, sometimes these symptoms can be causing an emergency. We have to deal with the emergency by giving a lot of hydration and taking care of the calcium levels. But if the patient is having subtle symptoms due to hypercalcemia, we can correct the hypercalcemia while simultaneously treating the patients for the symptoms of hypercalcemia. So in general, all of these treatment modalities are dependent on what is the symptom that the patient presents with. The emergency situations could be that a patient presents with a pathological fracture of the spine requiring immediate surgical intervention by a neurosurgeon or a spine surgeon, by which you have to make sure that the surgery is done as soon as possible, without which there could be long-lasting weakness of the lower limbs, and that could be very difficult for us to recover. Multiple myeloma is not treated by just one way. There are multiple factors that are important when an oncologist like me decides to start treating a multiple myeloma. Let's start with the important factors. Age of the patient, general condition of the patient, financial situation of the patient, and multiple other logistical factors are very important. With regards to disease, the disease-related factors, they can be divided into the stage of the myeloma, the organs that have been damaged by the myeloma, and multiple other issues such as comorbidities which the patient may be having are all important when we decide to plan on the treatment of multiple myeloma. The medications that are required for treating multiple myeloma are divided into targeted therapy. In this, we use certain targeted therapy drugs such as proteasome inhibitors, immunomodulatory drugs, which are considered to be the standard backbone of the treatment of multiple myeloma today. Remember, the stage of multiple myeloma helps in deciding many of these medications. The next category of medicines available is immunotherapy. Immunotherapy is a very important component, and that is usually reserved for multiple myeloma patients who have high risk disease or higher stage disease. Molecules such as daratumumab are not cheap, they are expensive, so they have to be used for the right set of patients. We still employ chemotherapy in a large majority of patients because chemotherapy is considered to be one of the most potent drugs which are there for the treatment of multiple myeloma. However, we do not use chemotherapy for all multiple myeloma patients. It's reserved for only a small subset of patients. Steroids are very useful, and they are considered to be in the backbone of treatment of multiple myeloma. Last but not the least, we use bone marrow transplantation. Autologous bone marrow transplantation and sometimes allogenic bone marrow transplantation are reserved when we have been successful in a successful induction therapy which employs the combination of targeted therapy, immunotherapy, steroids and chemotherapy in different contexts. Once we have achieved the maximum cell kill, where we achieve 99% of the destruction of the multiple myeloma cells by the target therapy, immunotherapy, corticosteroids and chemotherapy, then we proceed to do an autologous bone marrow transplantation for these patients, by which we will be able to provide the chance for maximum disease control in these patients. If we do not do a autologous bone marrow transplantation, the disease may come back soon. The autologous bone marrow transplantation is done so that the disease can be kept at bay for as long as possible. What is the role of allogenic bone marrow transplantation? Allogenic bone marrow transplantation is usually done in those multiple myeloma patients who present at the youngest age, like 40s or late 50s or somebody like that, who have a very good general condition and who have the logistical can we cut this part?
Yeah, please continue. We'll cut particular this part.
Allogenic bone marrow transplantation is reserved for those individuals who are in the age of 40s and 50s, who are financially capable of undergoing an allogenic bone marrow transplantation and who want to attempt to get cured from multiple myeloma. Allogenic bone marrow transplantation has been able to provide cures for some set of patients if it's done successfully, and it is not usually recommended in the older age group. We also have the latest technologies available. This technology is called as a CAR-T therapy, which is now available in our country and can be provided to a large number of patients who can afford this treatment. CAR-T therapy. This therapy has revolutionized the way multiple myeloma is being treated in the first world countries, and it is now currently available in our country as well. The full form of CAR-T therapy is chimeric antigen receptor T cell therapy. In this way of treating patients, we take the T cells of the patient and we expose the T cells to the cancer cells, that is the myeloma cells, in the outside culture medium. During this period, the genetics of the T cells is altered in such a way that when they are reintroduced into the body, they will only target the multiple myeloma cells and nothing else. This tweaking is called as the chimeric antigen receptor therapy, wherein the T cells are made in such a way that when they enter, they will not attack anything other than the myeloma cells. It is difficult to explain this therapy in just a few sentences, but we can surely say that this form of therapy, when it is processed and made much more refined, will help us in truly treating a large number of myeloma and probably even cure.